morning. Today's conference is about local anesthetics, pharmacology, and toxicity. We will start from the little history. The definition is a chemical compound that causes irreversible loss of nociception of local body region without the loss of consciousness. The discovery of local anesthetic was intriguing. Goes back to 700 BC's. First came from the origin stems from coca leaves, genus of the Retoxylum discovered in South America, Venezuela, Bolivia, and Peru, pre-Columbian periods. The leaf contains high concentration of alkaloid cocaine, that's about 2.7 to 1.8%. That was cultivated around 700 BC in Bolivian Andes. New discoveries showed humans used coca more than 5,000 years ago in Ecuador. After the Spanish invasion, Alfred Boller hypothesized that a tribe in the Negro River area called Araucao was the original discoverer of the properties and functions of the cocaine. In 1571, Pedro Pizarro of Inca observed nobles of the high rank officials using a cocoa plant. After following the Inca Empire, coca consumption spread widely to the population. The development of local anesthesia in Western Europe started around 1750 through 1850. Chemists and physicians were collecting samples of coca leaf for the experiments. In 1860, German chemist Albert Neumann successfully isolated active principle of coca leaf and he named it cocaine. 1875, Wilhelm Lawson determined the correct molecular formula of the cocaine, and Neumann discovered the effects of numbness of the tongue caused by the alkaloid by placing the coca on his tongue. Based on Neumann's discovery, Russian physician Basil von Andreyev did experiments on animals, and by injecting a small quantity of 1% solution to his tongue also, he noticed that the tongue became insensitive. So it's around that period a lot of the experiments produced a lot of addiction among the physicians who were doing studies. More physicians began the research of cocaine in the clinical trials. Physician Sigmund Freud used it as a stimulant to treat morphine addiction in patients, and ophthalmologist Karl Kohler realized the importance of alkaloids and anesthetics effect on mucous membranes, and as the first one in 1984 he used on a patient with glaucoma. Freud, House, and Kohler all became addicted to the drug through self-experimentation. In 1878, Professor Braun introduced procaine. That was the first derivative of cocaine, known as the first synthetic local anesthetic drug. And today's trade name of that is Novocaine, still used. Problems with procaine has generated due to the long onset. To produce the desired anesthetic result, quick time to wear off, nearly not as potent as cocaine. Also, a lot of allergic reactions were observed as esters have higher potential for the reaction, forced to use high concentration of adrenaline that result in increasing heart rate and anxiety. The development of lidocaine occurred in 1940, was developed as a derivative of xylidine, and was the first modern local anesthetic agent used broadly. Local anesthetic structure, it has primarily three components: lipophilic component to the left that contains the aromatic ring, connecting chain, which is either ester or amide, and ionizable group, that is the hydrophilic portion to the right. Structure of amides and esters. Examples: cocaine, procaine, benzocaine, tetracaine, chlorocaine, all as you can see, and all of them contain the carboxylate alkali group and an ester linkage. And amides, lidocaine, mepivacaine, ethylocane, bupivacaine, and prolicane contain amino amides group. Overview of chemical properties. Local anesthetics are weak bases that exist as either uncharged base or cation, and proportions between the base and the cation depends on the pKa and pH, as described by the Henderson-Hasselbalch equation. Most local anesthetics have pKa's ranging from 8 to 9, therefore at physiological pH most local anesthetics molecules are in a cationic form. That cationic form is responsible for the physiological activity at the receptor site. Uncharged form is important for the penetration across biological membranes to reach the site of action. Local anesthetic receptor is delocalized at the internal side of the cell membrane. Continuation, local anesthetic chemical properties. Used as a racemic mixture of enantiomeric isomers, chiral agents, and containing asymmetric carbon left or right sided configuration racemates like mepivacaine and bupivacaine, which is about 50-50 mixture of S and right enantiomers. It's basically a structural, it's a spin either to the right or to the left. Ropivacaine is pure S enantiomer of bupivacaine and is much less toxic than racemates. Usually the molecules that spin to the left are less physiologically active and they are responsible for more side effects. Mechanism of action. We should consider first the chemical aspects alone based on the balance between lipophilic and hydrophilic characteristics and potency of stereoisomers like ropivacaine and mepivacaine. Second consideration is the interaction with the receptor. The mechanisms based on depression of rate of electrical depolarization, failure to achieve threshold potential level, lack of development of action potential, and conduction blockade. Factors affecting action is a pKa. The lower the pKa, it's the translates into a more rapid onset. More local anesthetics in an ionized form diffuse easier to the membranes. Local anesthetics with pKa close to physiological pH are associated with more rapid onset of action, better ratio of unionized to ionized drug. Another properties affecting the onset: lipid solubility. Increased lipid solubility translates into increased potency. Protein binding. Vasodilator properties of local anesthetics affect duration. Increased protein binding causes increased duration of the action. Esters typically have shorter duration of action compared to local anesthetic with amide linkages. The vasodilator properties of the local anesthetic affect both potency and duration of action. The more enhanced systemic absorption, the shorter duration of action would be. For example, lidocaine causes greater vasodilation compared to mepivacaine or ropivacaine, and therefore is associated with shorter duration of action. Other factors: lipid solubility. The greater lipid solubility leads to increased tissue sequestration and reduced drug available, produces shorter duration. The examples: mepivacaine plasma concentration is higher than for bupivacaine. Absorption and distribution factors. Injection site. Around the injection site, what's important for consideration is tissue vascularity. The high vascular area, like epidural space, promotes rapid absorption, resulting in blood levels. Right? Especially we can see it in the pain management when the patient comes with inflammation in the epidural space. You inject a lot of local anesthetic, and the absorption is quicker, they're more prone for side effects. Poorly vascularized area, tendon associated with relatively poor absorption, so you are free to use more local anesthetic there. Regional anesthesia, maximum blood levels, highest to the lowest. Examples, intercostal is the highest, through the caudal, epidural, brachial plexus, and sciatic nerve being the lowest. Another factors affecting the absorption distribution is dosage and chemical properties of the drug. Examples, cocaine or pivacaine to some degree more pivacaine, have some intrinsic sympathomimetic and vasoconstrictive properties. On the other side, the lidocaine and bupivacaine do not. So, technically speaking, we are using more and more often in performing epidural injections those anesthetics that has this sympathetic vasoconstrictive activities that can maintain the local anesthetic and into epidural space for a longer time, and also cause less toxicity. Other factors, presence of vasoconstrictors, reduced systemic absorption due to local vasoconstriction, increased neuronal uptake, resulting in higher local concentration. With use of local vasoconstrictors, we can achieve as much as 1/3 less blood levels of the local anesthetic. And presence of vasoconstrictors have a particularly significant effect for the local anesthetics with intermediate and short duration of action, like procaine, lidocaine, and pivacaine. Vasoconstrictor addition has a lesser effect for more lipid-soluble agents. The lipid solubility of these agents tend to keep them in the local tissue site intrinsically. Right, and not really to have effect on the absorption through the vasculature. Examples of bupivacaine and lidocaine, clamidine epidural anesthesia enhances and prolongs the local anesthetic by reduction in neuronal activity and inhibition of substance P release. Absorption and distribution, plasma concentration determinants, rate of tissue distribution, rate of drug clearance. Amides have a hepatic clearance with minimal renal excretion of unchanged drug. Esters have a rapid clearance, short elimination half-time due to rapid hydrolysis by plasma pseudocholinesterase. Other factors is patient age, liver function, cardiovascular status, protein binding. General amide local anesthetics agents tend to be more widely distributed compared to ester local anesthetics. Another determination is pulmonary extraction, resulting from venous circulation, limiting the amount of local anesthetic that will reach the systemic circulation. Neurotoxicity of the local anesthetic, the toxicity and neurotoxicities. First major concern is allergic reaction that can occur with a frequency of less than 1% of local anesthetics. Higher risks are produced by the ester-type local anesthetics, especially those that are metabolized to the paramino benzoic acid-related compounds. Allergic reaction following local anesthetic administration may be caused by preservatives as well, like methylparaben-related structures, including the preparation. Preservatives are structurally similar to paramino benzoic acid. Another issue is antibody production that may be induced by the preservative as well, not actually the reaction to local anesthetic. Cross-sensitivity exists between local anesthetics, may be due to common metabolite profile to paramino benzoic acid. How do we test? Clinical history, intradermal testing, suggestions of the presence of allergy, there's a rash, urticaria, laryngeal edema, passive hypotension, bronchospasm. there are considerations that should exist, right? It's about performing those reactions, hypertension and syncope tachycardia following epinephrine containing local anesthetics from accidental intravascular injection. For intradermal testing, preservative-free drugs should be used. Systemic toxicity of the local anesthetics caused by the excessively high plasma local anesthetic concentration. Determinants is the rate of entry into the systemic circulation balanced by redistribution to tissue sites and clearance. And that really depends on the initial dose of administered medication, injection site vascularity, whether or not epinephrine was used, properties of the drug itself that produces secondary high plasma concentrations. Most common causes of toxic plasma local anesthetic concentrations: accidental direct intravascular injection during peripheral nerve block or epidural anesthesia. We are trying to avoid that by aspiration and confirmation with the injection of the dye solutions. Other causes: toxic plasma levels, excessive absorption from injection site without intravascular injection. It's quite common in epidural injections, also sympathetic blocks. The paraspinal regions, where the needle is placed for sympathetic injections, contain also a lot of blood vessels, and the local anesthetic can be easily absorbed from that location as well. Somebody who injects quickly a lot of volume to do the sympathetic block, and it's very close proximity to vasculature, you can produce toxic amount of local anesthetic levels. Okay. Prilocaine is known to cause beta-hemoglobinemia. Local anesthetic side effects consideration can be caused by the methemoglobinemia. Systemic toxicity of prilocaine is comparatively low. However, its metabolite toluidine is known to cause it. That's the exception. Cardiovascular system, conductive system of the heart, is quite sensitive to the action of local anesthetic. Treatment of the overdose, something with a technique called lipid rescue, by using the medication substance called intralipid. Commonly available intravenous lipid emulsion that can be effective in treating severe cardiotoxicity secondary to local anesthetic overdose, including human case reports of successfully using this method. So there are not really specific medications to reverse local anesthetic toxicity. We're trying just to unbound the local anesthetic from the receptor side. CNS toxicity, local anesthetic, goes through a development of sequence stages. The first one being the circummolar numbness, even with low concentration. Then patients will develop initial symptoms like tinnitus, vertigo, and restlessness. Those changes happen quite fast, and a lot of the time tonus circummolar numbness goes so quickly into restlessness of the patient that a lot of the time we even forget to ask patient if there is any sensation. And first we notice is the restlessness of the patient. Subsequent symptoms: slurred speech, skeletal muscle fasciculation, going to muscle twitching, immediately preceding seizures, dartonia and cloning, and final loss of consciousness. Factors influencing CNS toxicity: plasma concentration, specific to drug dependent, lidocaine, mepivacaine, pryolane, CNS effects at 5 to 10 micrograms per ml, bupivacaine, CNS effect causing seizures between 4 to 5 micrograms per ml. Rate of injection site may be more important than total amount of drug injected. That happens quite often, actually, comparing to sustained levels of the local anesthetic. Active metabolites contribute to additive toxicity with lidocaine following through administration monotyloglycine zolidide. Seizure thresholds. Patients who are taking medication decreased seizure thresholds have increased possibility to the side effects. Inverse relationship between PaCO2 and local anesthetic related to variation of cerebral blood flow and drug delivery. Hyperkalemia promoting depolarization increases local anesthetic toxicity. Hypokalemia promoting membrane hyperpolarization decreases local anesthetic toxicity. Treatments. First focus of treatment of seizure to assure adequate ventilation with oxygen. As we face rapid onset of arterial hypoxemia, metabolic acidosis, and next is seizure suppression, primarily using benzodiazepines, vertebral Valium. And in conclusion, I place a table that contains the anesthetic, the most commonly used anesthetics, PKA onset, duration with epinephrine with minutes, and maximal dose with epinephrine. Thank you.